Thank you. So, by way of introducing myself, my name is Don Allensworth-Davies. I'm an associate professor in the Department of, I'm making sure I have my mic on.
It is.
Okay, good. All right. Sorry, lost my flow there for a second. So I'm an associate professor in the Department of Health Sciences and Human Performance at Cleveland State University, where I also serve as coordinator for our Master's in Public Health program, of which Neomed is certainly part of our consortium. I was invited to do this presentation by Kay Siebert before she retired. She saw me give a longer version of this as part of the Portage County Opioid Conference and asked if I'd be willing to come and speak with all of you, which I'm very excited to do. So, my primary training is in health services research. I trained at the Boston University School of Public Health. I worked for several years in the addiction health services research sphere when I was working on my PhD in Boston. And I'm now circling back since I am now a substance use counselor in training. I expect to be sitting for the national exam in a year. I also do some part time work as a peer recovery supporter, and I also identify as a person in recovery and as a cisgender gay man. So, all these things um, are what are sort of what are inspiring and brought me to our presentation today. So today, the main thing I want to talk about in the time that we have is how rates of substance use disorders, particularly in LGBTQ plus communities, are different from their straight or heterosexual counterparts. And one of the questions I get asked the most whenever I'm doing these presentations is how can I be a supportive ally to my patients who might be members of the LGBTQ plus community? So that's something else I'm going to include in our discussion today. And then I'll be wrapping up at the end with a brief case study that I created just for you for today with a few discussion questions so we can apply some of the concepts as part of our session today. So just as an overview, long historical association in this country between identifying as lesbian, gay, bisexual, transgender, queer plus, and substance use disorders. So it's estimated that there are give or take a couple million LGBTQ plus adults who have a substance use disorder, whether that's alcohol or illicit drugs. 1.5 million reported having both SUD and mental illness. And for we who work in this area, we know that mental health conditions like depression, anxiety, suicidal ideation track very closely with the use of substances. Almost 6 million reported having mental illness alone. So mental illness in general in the LGBTQ plus community is a huge struggle. As you might expect, a lot of this comes from being a sexual and gender minority within a larger population and feelings of internalized homophobia, stigma, discrimination, etc., that you would encounter in society. Approximately 40% of SGM adults reported past year use of marijuana, which is more than double of what you would find in the overall US adult population. And slightly more than 1 million reported receiving medication assisted treatment for opioid use disorder in 2018. Similarly, for alcohol use, pretty close actually. So 64% report alcohol use, which is just a little bit higher than that of the overall US population. Research has shown that transgender women are more likely to seek treatment for substance use disorders compared to non-transgender individuals. And we've also seen elevated rates of smoking and vaping in this community compared to their straight or heterosexual counterparts. Alcohol use disorder. This I found really interesting. So this is a fairly recent study. It's one of the few longitudinal studies that I saw in literature, which looked at slightly more than 1,000 sexual and gender minority participants. And as part of this study, what they found was that gay and bisexual males between the ages of 18 and 45 had the highest rates of alcohol use disorder in the population of study. Lesbian, gay, and bisexual females were most likely to meet the criteria for alcohol use disorder, particularly those who are between the ages of 45 and 55, which also tracks, I think, overall with numbers that we would see specific to alcohol use disorder. Alcohol use disorder tends to become more of a problem for a lot of people later in their lives. And so typically, people will meet the criteria for alcohol use disorder within a similar age range as what we're seeing for the lesbian, gay, and bisexual females. Also, SGM adults who experienced discrimination in the past, not unsurprisingly, also had greater odds of alcohol use compared to their straight or heterosexual peers. And this is especially true in the 23 to 34 year age range, as well as the 42 to 53 year, with the association between discrimination and alcohol use disorder being strongest among sexual minority men. And sort of related to this, I think it's also important to note that the LGBTQ plus community has a very long history of gay bars. Certainly, as a newly emerging gay man in the 1990s, the gay bars were places where members of the community could come together, feel safe, feel comfortable in their sexual and gender identity. It's where you met potential boyfriends, girlfriends, partners. And this history in our country actually dates as far back as even the 1920s, 1930s. Now, at that time, the bars were very much underground, and you really had to know, someone else who knew about their existence. Um, then fast forward to the Stonewall riots in 1969 when the gay bars became visible on a national level. But I have it in good faith from younger generations of counselors that I've spoken to that the gay bars are still very much a thing today. And so obviously, when that plays such a significant role in the culture of a community, in addition to creating a safe space for that community, it also carries the risks that come with alcohol use. And then finally, just a little bit about youth. So, and this would be youth specifically lower than age 21, so teens. The source for this information is the Trevor Project, if any of you are familiar with that organization. Approximately half reported using alcohol in the last year. About a third reported using marijuana in the last year. 10%-ish reported having used a prescription drug that was not prescribed to them in the last year. Similar amount also reported regular use, defined as daily or weekly use of both alcohol and marijuana. Experiencing conversion therapy was associated with 25% greater odds of regular alcohol use or regular marijuana use. So that's often a traumatic experience for members of the LGBTQ plus community. Regular prescription drug misuse was associated with almost 3 times greater odds of attempting suicide in the last year. So that's just among youth. So other risk factors to keep in mind for this population: discrimination, social stigma, family rejection, especially family of origin. It is not unusual for LGBTQ individuals to not have contact with their biological family. I'm actually an example of that. My family pretty much disowned me when I came out in my 20s. I probably haven't had contact with any member of my biological family for 30 years. And so often what ends up happening is they end up creating families of choice. People that they feel especially close to in the community, or mentors that they identify for themselves in the community. Lack of support, especially around the coming out process, or if they are struggling with stigma, internalized homophobia, discrimination. And then, of course, internalized homophobia is also very common, especially in those early years after someone is either attempting to come out or may have just recently come out as an LGBTQ individual. Okay, so any questions on or comments on that so far before we jump into allyship? Okay, hearing none. John, is
And
there anything in the chat?
as a reminder, if you do have questions, you could place them in the chat and we'll make sure the speaker gets them.
Awesome, thank you. All right, so allyship, as we define it in the safe space trainings that I've done at Cleveland State, is a process of growth and development. And I think it's really important to remember that no one is perfect and everyone has to start somewhere in terms of learning how to become an ally, especially to marginalized and minority communities such as the LGBTQ plus community. So in the LGBTQ plus community, just maybe a few updates on language. So sexual preference is no longer a term that is used in the community. The term sexual orientation is preferred. instead of lifestyle, a term like LGBTQ plus identity. Though honestly, what's becoming a lot easier right now is I'm very happy to say the letters are starting to go away. The letters have always annoyed me, like ever since they started using them in the 80s and 90s. But I'm very happy to say with the up and coming generations, they actually prefer the term queer. So queer identity or LGBTQ plus identity, depending on the generation that you're working with. A homosexual, the gays, though the gays was made very popular by the comedian Kathy Griffin, it's still probably better to say queer person or LGBTQ plus person. Sex change is almost never used. I haven't heard that term in years. Instead, we use the term transition for transgender individuals. Instead of biological sex or born a girl or boy, sex assigned at birth. And instead of referring to someone as transgendered or a transgender, referring to them as a trans person or transgender person, which is pretty similar to what best practice is in the addictions field. And so at least certainly with my clients, I do not refer to them as addicts. I refer to them as a person with a substance use disorder or a person with an alcohol use disorder. So that the person doesn't get lost with the label. So that's the last thing I think any of us want to do for our clients is burden them with a negative label without recognizing their autonomy and their personhood.
Don, we
So
have a question.
yeah,
In the Trevor Project study, what was the prevalence of persons experiencing conversion therapy?
that I do not know, and I would have to look at honestly.
Okay.
So the 25% number was of those who reported conversion therapy who turned to alcohol and marijuana. But what the overall prevalence was, I do not know. But that is a very good question.
And there's also, not only is there the formal conversion therapy, which isn't recognized in many states, which also means it is recognized in some. There's the informal conversion therapy of taking
Mhm.
someone to a church leader or doing a family intervention.
Yes, which is important to recognize. And often the informal versions of conversion therapy are the ones that are least documented. So I would assume that the numbers that the Trevor Project was able to receive was based on formal conversion therapy. Though depending on how open their participants were in their study, there may have been some informal incidences in there as well. That's a good point. Thank you. Any others?
Yes, and there's another one. At Neomed, they're going to be doing a chart review of AUD and SUD screening or referral for adolescents and pediatric care. What would be a responsible way to include gender identity in the study?
It may not be an option if it's a chart review, depending on. I'm assuming this is going to be an electronic medical record. And so that's really going to depend on what the source system is. Most of the healthcare organizations that I've spoken with do not capture sexual orientation or gender identity, for example, as part of their EPIC system. A few are working to add it, but really the only healthcare organizations that I've seen that capture that kind of information would be specifically LGBTQ health centers, such as what we have at Metro Health. Otherwise, it might not be possible, honestly, to capture gender identity or sexual orientation from chart review alone.
Okay, I that's sort of what I thought. And that's not something that you would necessarily screen for. So, or ask about. So that's okay. Thank
Well,
you.
that kind of depends on the clinician. I mean, the problem with a chart review, if you're using that as the basis for research, you want to know that that information is being captured consistently. Now, as a clinician, I think yes, you should always, to the extent that they're comfortable sharing with you their sexual orientation or gender identity. Yes, it would be good to know that. Yes, it would even be good to document that somewhere in the medical record. But the problem is, it's not an actual field in the medical record. And so it'll be recorded very inconsistently.
And Dr. Goldman mentions that Seattle Children's uses a question where they ask or they ask a specific question, but he can't remember the name of the software. So it seems like there are questions being asked, but they're being asked in different ways. So it's
Yes.
universalized of how to approach this and accurately find the representation.
Right.
Uh,
And there's a lot of the literature actually has really good suggestions on how to phrase these questions for sexual orientation and gender identity. And some medical centers, such as Vanderbilt, have published white papers describing their experience of integrating sexual orientation and gender identity into their electronic health record. So there's guidance out there for people who would like to use a more standardized question or one that's more widely used.
And we have some glossary questions. Can you do a real quick definition of cisgender and of what conversion therapy is?
Yes. So cisgender, very quickly. Actually, I'll use myself as an example. Um, I was born male, so my sex assigned at birth is male. I identify as male and present as male. So I would refer to myself as a cisgender male because the way that I present and identify matches my sex assigned at birth. And so if it did not, if, for example, I was in the process of transitioning and my choice was to present and identify as female, then in that case, I would identify myself as a transgendered female or a transgendered woman. So that's the main difference. So cisgender, it's exactly what it means in biology, the same. So how you present, how you identify is the same as your sex assigned at birth. For conversion therapy, it's basically how can I describe it? It's um, it's almost a punishment-based therapy where you're forcing an individual to more favorably view and engage in opposite sex interactions and punishing any inclinations they have towards same sex interactions. And so, as you might expect, when conversion therapy, now in a church context, it's often done with a lot of religiosity, a lot of like praying over the individual, or what we call praying the gay away, a lot of, in some cases, actually even to the point of physical abuse. In a formalized treatment setting with a therapist, it would be ways of identifying how to reward same sex inclinations and how to dissuade or punish oneself for same sex inclinations and interactions, which, as you can imagine, can be very psychologically traumatic, especially if the client is being forced to attend by their families or other individuals, and it's not their own choice.
Thank you.
You're welcome. All right. So finishing up with allyship. Just keeping in mind, and I like to think, I mean, certainly in counseling, we have a very patient-centric, humanistic approach. And so we always want to make sure that what we're doing is in the best interest of our client. So remembering that it's about the other person's comfort, not necessarily ours, it's important. And if you make a mistake in referencing to someone, so if you misgender someone by accident, which is very easy to do, I've done it myself, it's important just to correct yourself quickly and move on with the conversation. And so if you really feel like you messed up and you want to have a brief interaction with the individual just to make sure that rapport hasn't been broken, you can certainly bring that up in a one-to-one private conversation at a later time. So some examples of ways to correct yourself. I went to the store with him. She and I went to the movies. They're a big fan of Marvel Comics. So keeping in mind that in addition to the he, him, she, her pronouns, we also have they, them. And if you want to take that to an additional level, there's also she, which is the gender neutral pronoun that will be used by some non-binary and transgender individuals. So what not to say when you correct yourself. She really likes, oh my gosh, I mean, I'm so sorry. I just don't have it down yet. You need to give me time. I mean, I'm getting it. I promise. It's just so hard sometimes. I don't even know where that came from. And I'm so sorry. I've never done this before. It won't happen again. This is what you don't want to do because this makes it all about you. So brief correction, move on. If you misgender someone who's a patient or a client, again, making note of their preferred gender is helpful for future sessions and actually will help other healthcare providers if it's documented. So, all right. And as far as labels go, and again, the nice thing about talking to people who work in addictions is just like we avoid giving our patients and clients labels. I mean, certainly if they choose one for themselves. So, for example, I have clients who self-identify as alcoholics because for them, that is a helpful label. Would I ever refer to one of my clients as an alcoholic? No, because I'm not going to put that on someone unless it's something that they have already identified for themselves. So it's sort of the same approach when you're working with LGBTQ populations. So let the individual choose what fits for them. And increasingly, most of them won't. Like they don't want the letters. Some of them don't even want to identify as queer. They just want to live their lives. Like, yeah, I'm attracted to guys and I date them, but I don't feel the need to call myself anything, which is fine. Also, not making assumptions about what labels are okay or not okay. So, classic example of this. So, when I first came out in the 1990s, this was during the HIV/AIDS crisis. A lot of activists, including ACT UP, were in the streets trying to get funding from the federal government for HIV and AIDS research. And queer at that time was still, from someone outside the community, was still considered to be a very negative word. And in the community at that time, the only people that used the term queer were activists. And they applied it to themselves for shock value in their activism work. Fast forward 20, 30 years. And the term queer has been re-embraced by the community. And in fact, for many is now a preferred term over the LGBTQI. Which for me, like watching this happen, has been very empowering. Because for the longest time, I felt like this wasn't a word that I was able to use. Because I was afraid of offending someone, or I wasn't sure if it really fit with me. But now that it's being sort of re-embraced by the community, and especially by the younger generations, it's in much more common usage. Though that said, there may still be people who would take offense to the term queer. So again, wait for the person to use it to apply to themselves. You know, if you're really worried, you can, ask them, is it okay if I use the term queer in our sessions together? And and if they're using it, they'll probably be like, yeah, no problem. But let the patient or the client signal that for you before you use it, just to make sure you aren't accidentally causing offense. In terms of the coming out process, I always say that if a patient or a client is coming out to you, that is a tremendous gift to any of us as a provider. That shows that they trust us. That shows that they have good rapport with us. That shows that that they know that we're creating a safe space with them. And so the most important thing to do when someone is coming out to you is to be fully present with them in that experience. Give them your full attention. And 9 times out of 10, you're not going to have to say anything. All you'll have to do is listen and be supportive. So a lot of times they've rehearsed this so many times, and especially with counselors and other therapists, you might be the test case. You might be the very first person they come out to before they start working out plans to come out to other people in their life. And so I always say, accept that for the gift that it is. And so the most important thing, of course, is just to affirm that identity. So whether they're coming out to you as non-binary, as a transgender man, as a transgender woman, gay, lesbian, bisexual, supporting them in that identity and really supporting them in their exploration of that identity is one of the best things I think that we can do. Also, have resources available, especially for the newly out. I think a lot of times there's an assumption that even people who have just come out are already going to know all about the gay community. Not true. So I actually have a little resource sheet that I've put together of local LGBTQ resources so that if a client does come out to me, I can slide this sheet over to them and say, hey, here are some organizations, here are some things that you might want to check out that might be helpful for you. And that gets them started. And so in order for us to do that, we also need to be familiar with what those local resources are in our community and which ones are going to be most appropriate for our clients. And then the other thing I'm also very aware of, both not just as an LGBTQ individual, but also as like a tall, bald white male, is the importance of creating space to allow other voices to be heard. And so I do this when I serve on university committees. So especially if there are not a lot of women on the community, I try to hold space for them and give them an opportunity so that their voices can be heard. If I am an LGBTQ individual and I know there's someone else who also identifies as LGBTQ, I'm happy to hold space for them because the perspective of a lesbian woman is going to be different than a gay man, which is going to be different from a transgender person. And so, to the extent that we can be allies by creating space for other voices and other perspectives, rather than trying to speak on behalf of others, that's a very useful skill to have. And then finally, to the extent that you're comfortable, like getting more involved with the community. So even though we're older now, my husband and I still make it a point of going to Akron Pride. Ohio Guidestone, who I do part-time work with right now, very tries to be very visible at Akron Pride. They always have a table there every year. Something as simple as educating yourself. So, like, read an issue of Out magazine, go to the Human Rights Campaign website, learn more about Land Illegal. This is a way to learn more about the community, what their current issues are, and also some resources. The other thing that's going to be interesting, and I've had this in my talks for a long time, pronouns are a really good way to signal, though in the current socio-political climate, I am wondering how much longer this is going to continue. So, for example, in my email signature, by me having my pronouns, right away, a member of the LGBTQ plus community is going to see that and go, he knows. Like he is potentially an ally because taking the time to put your pronouns as a way of signaling can often help members of the community trust you more and help you more readily build some trust and rapport with them. And also, finally, just not assuming that everyone is heterosexual. This happened to me as an early faculty member. It was really funny. I don't know if it's because I'm tall. So for those of you who, I don't think any of you have seen me in person, I'm 7 feet 2 inches tall. So I kind of stand out at like receptions and things. And I remember one of my early faculty receptions, a woman came up to me and said, "Oh, you're so tall. Is your wife tall too?" And I looked at her and I said, "Well, actually, my husband's 5'11". And she immediately like looked at the floor and walked away. She did not know. She was not expecting that. So again, not making assumptions, using terms like partner, even instead of boyfriend, wife, until you learn that your patient or client is using those terms, is helpful because it just helps keep the conversation open. And then finally, before we jump into questions and case study, just some things to consider for your LGBTQ plus clients from a healthcare perspective. So conducting confidential client satisfaction surveys that include questions about sexual orientation and gender identity. That doesn't, just because we don't collect it in our electronic medical record system doesn't mean we can't ask about that on satisfaction surveys. Asking clients and families specifically about staff responsiveness to their needs during their experiences of care and treatment and whether and how those needs were accommodated. If you have a board, whether it's a community advisory board or a board of directors, consider including LGBTQ plus members as part of that board. And they can often provide valuable insight and guidance when it comes to those populations. Making sure that your marketing efforts are including LGBTQ plus audiences. This can be something as simple as having, like Guidestone does, have a table every year at Akron Pride. It makes your organization visible and it signals that you are a friendly organization to the LGBTQ plus community. And then finally, if you have services, programs, or initiatives that are specific to LGBTQ plus individuals, for example, maybe you offer facilitated support groups for transgender women. Make that known on your website. Make that known in the community. Not only will that attract more clients to your organization, but it's a sign of showing that you support the community. All right. So, any comments or questions before we talk about Alex?
We did have one from Dr. Block. He mentioned that he had a client, and he even said it'd be a great lapel pin idea. But his client said, my pronouns are ask me.
I like that. And I've been to conferences, even APHA, sorry, American Public Health Association, where they have buttons similar to that. So you can either choose specific pronouns, or I'm pretty sure they had one that said ask me. I think that's a brilliant idea. The other thing that's really helpful is I had a primary care doctor. As soon as he walked into his office suite, he had a pride flag and a transgender flag visible in the windows. And so, me as a gay individual walking in that office suite, immediate signaling to me that this practice was welcoming of LGBTQ plus individuals. So, but I love the idea for the pronoun button. I agree with that. And lapel pins are good for that. Even if something as simple as a rainbow flag on your white coat can be positive signaling to the community. Any other questions or comments before we move on? All right, as we say in faculty land. Oh, is there one, John?
Yeah, I'd like to ask. I've had a patient, or actually more than one, who told me, I'm human. I'm a person. I don't want to be labeled.
Yep.
And they were very offended by all the letters and all the names and pronouns and things like that.
Yep. And I think it's important for us to respect that. And that's a good example of what I've been seeing. I mean, I don't know what generation these were for you, but certainly among the younger generations, they don't want the labels. They're actively rejecting them. And so, first of all, I think it's great that they felt comfortable enough with you to share that with you. And secondly, absolutely respect that. I mean, it gets confusing and it kind of makes things harder than they need to be, I think, in some ways. I mean, it's important from a health disparities standpoint to have some way of identifying these populations. So, for example, in the research work that I do, the most common term is sexual and gender minorities, which is very broad, kind of includes everybody. And that's just so we can report on health disparities and things about the community that might be different. But otherwise, I kind of agree with them. It can become cumbersome.
Thank you.
Thank you. Anyone else?
I think we're good.
All right, case study. And I'm keeping an eye on the time. I know you guys run a tight ship, so. So let's talk about Alex. So Alex is a 30-year-old transgender male, meaning his sex assigned at birth is female. He has struggled tremendously with a combination of opioid use disorder and an alcohol use disorder. He was referred to a treatment facility after a series of relapses, which is certainly not uncommon. And I don't mind sharing that I myself had several relapses before I finally got sober. So it's a pretty common experience in the addiction realm. And a worsening of addiction to opioids and alcohol. So his substance use really has become a coping mechanism for managing internalized transgender phobia, as well as external discrimination related to his gender identity and his social interactions. So Alex, overall, he's in generally good physical health, no major chronic conditions. He has a few conditions as a result of his substance use. So he does have some liver damage from the alcohol consumption, and he occasionally gets infections related to his IV drug use of the opioids. He has a history of depression, anxiety, exacerbated by gender dysphoria. So, gender dysphoria is basically when an individual doesn't feel that their physical gender matches how they perceive themselves. So, if you talk to transgender individuals, they will often describe themselves as being born in the wrong body and often having a lot of hatred towards that body and towards themselves because they're not the person that they feel that they should be. He's been undergoing hormone replacement therapy for 2 years, so he has been seeing some of the physical changes of the transition, but he still experiences significant emotional distress linked to body dysphoria and feelings of social rejection. And so, one of the things that Alex has been struggling with is how to appear more masculine and pass more effectively as a man, without there being any traces of him previously having been a woman. So Alex's substance use began in his late teens, which is actually pretty common among LGBTQ individuals. That's usually when we started experiencing bullying as a result of either our gender identity or sexual orientation or both. That's often when we tend to feel more isolated. That was certainly the case for me as well. I came out when I was 18 years old. So I definitely started drinking very soon after that. Some start as early as 14 or 15 years old. Initially, it was just recreationally, but over the years, as happens with substances, intolerance increases, it escalated to problematic levels. So his main substances of choice are opioids, specifically heroin and prescription painkillers and alcohol. He reports that he's been using substances as a way to numb his feelings of isolation, shame, and the challenges associated with his transition. Alex's family has a history of alcohol use disorder. His parents have shown very little support for his gender identity. They've actually greatly reduced contact that they've had with him around this. He tries to spend as little time as he can visiting his parents because he knows that they don't approve of his transition and it makes him very uncomfortable. So as a result, his relationship with his family is very strained, and he definitely reports feeling rejected by his biological family. So he's had significant psychological distress. The gender dysphoria often leads to deep anxiety and depression. The depression, especially when he's really deeply in it, could last for as long as days or weeks at a time, which he definitely finds difficult to manage without the aids of substances. His experiences with transphobia, discrimination, and lack of acceptance in both his family and social settings have contributed to isolation and feelings of unworthiness. He's been in rehab multiple times and has relapsed every time. And on at least one occasion, left treatment early. It was only there for a few days and did not want to remain because there were no other LGBTQI individuals and he was feeling very unsafe. He's received some counseling, but feels that the traditional recovery programs are just not equipped to address his unique needs as a transgender person. So, questions for you. So, what specific treatment modalities might be particularly effective in treating someone like Alex, who's managing both substance use disorder and gender dysphoria? So, as a provider clinician, how would you approach
peer
Alex?
Supporter would be helpful for him if he could be matched up to someone who's gone through the same struggles.
Okay, and would you recommend that it be a transgender peer supporter if possible?
Yeah, I think someone who would reflect his identities but then on the other hand, what worked for that person might not work for Alex. So you also want it to be someone who's open-minded and not interested in just advocating for what worked for them.
Right. Which is also part of the peer recovery training in the state of Ohio. So to be a peer recovery supporter, you need to be state certified, and that's something they included in their training, which I'm very happy to say. Excellent. Other thoughts?
Well, I was just going to say that I think it's less important what the treatment modality is, but that the provider be somebody that's sensitive to, his issues. That's basically the most important thing. So even if that person is, cisgender straight, as long as they understand, I think they're, that you could get a good therapeutic relationship. But yeah, a person that has more understanding or knows about people that have gone through transition and stuff is probably better than any specific treatment modality per se. That's all
Yeah.
my comment.
Don, I think no matter which treatment modality you use, we have to have some treatment planning around the social element
Right.
of what they do after treatment. And we also have to know our community because some communities are more entrenched in stigma than others. And as such, even 12-step meetings, and I'm a member of a 12-step culture, but I can also tell you that the 12-step culture isn't the cross section of all the healthiest people on the face of the earth in the first place.
Right.
So there are some of those social stigmas and political stigmas that encroach on those meetings.
Hmm.
Now, with AA and NA, you could go to the national website and look for a meeting, and they now have where you can find meetings that are for men, for women, and they do have LGBTQ
Yep.
meetings now. So to at least find some social element to replace the bar scene might be important because, like you said, that bar scene is a safe place and
Hmm.
it's been ingrained in their, social life for a long time,
Hmm.
and it doesn't work well with SUD treatment.
Exactly. And also, and actually, this is something I should probably talk to. I don't know how many of you are familiar with Toddlers Redemption in Akron. It's a recovery community organization. That actually those might represent safer spaces for LGBTQ individuals. Just as a place that's more comfortable, a little less formal, a place they feel like they can go, as an alternative to the bar scene. Still as a way to network and meet people and sort of know that they're in a substance-free environment. So there might be some options there. Also, other peer recovery support organizations such as Smart Recovery also has dedicated meetings for LGBTQ individuals. And Recovery Dharma, which is based on the Buddhist precepts and meditation, is pretty much welcoming of everybody. So that's also been a very supportive place for LGBTQ individuals. So excellent point. Thank you. So for the next one, the one I'm most interested in is what barriers might you see in traditional recovering settings for Alex, and how might these be addressed?
A lot of times the barrier is going to be on the strict definition of gender because there's a lot of agencies that have gender specific programming. But which side of that does a trans individual go to? So it's really a matter of fit, and that can be a barrier because is there enough of that population to have its own dedicated group? In most areas, no. So it might mean that to offset the group experience, maybe to add individual counseling at a greater level than with other individuals.
Mhm. That makes sense. And this is especially, I think, evident if you're looking at inpatient rehab, which is often divided along gender lines. And so if you have a transgender person, I mean, where would they fit into that inpatient rehab environment? Other thoughts on barriers?
Family support groups are another one.
Mm.
There are
But this
some
is where it
groups
can
that,
get tricky because right now Alex does not have a good relationship with his family. So
but does he have people in his life that operate as a family?
yes,
And
that's
maybe
the
more
question.
family.
So identifying even family of choice, and actually, to be honest, so I'm taking a course right now in assessment for counselors, and my instructor is a huge fan of genograms for that because genograms, obviously can be used as a biological family, but they can also be really helpful in identifying a family of choice. and the relationships that person has with them. So, and I don't, hopefully all of you are familiar with genograms. They're like little family diagrams, usually useful for social and family history, but can also be adapted for other things. So,
We also had a comment that eating disorders are more prevalent with the trans population than maybe with the general population. So another problem area to consider.
right, because they are so focused on that, on that passing appearance, right? On assuming that new gender identity. And so they are going to obsess much more over how they present and how much they weigh and how they look and am I masculine enough? Am I feminine enough? So absolutely, that's a good point. I can tell you, at least among transgender men, one of the big things that they all work towards, and it can take a number of years, is top surgery. So that's top surgery is something that is very highly valued in the transgender male community. All right, let's move on to the last one, and then we can open it up for questions. Um, so what about strategies to help Alex prevent relapse? Especially knowing that Alex is struggling with gender dysphoria and feelings of rejection, and maybe even some internalized hatred because Alex isn't presenting the way he wants to present yet.
Well, to me, this is where the individual therapy kind of comes in. It's not something that would necessarily be covered like in a group setting. And so just having that flexibility, I think would help. Because I think a lot of this is about, self-esteem and working on negative self-talk and those kind of things, which is, quite different than traditional SUD treatment, per se. So, and again, just being able to have Alex find his tribe, just his group of people that he feels very comfortable with. I think that's the best thing that you could do in terms of the social rejection part is you got to find the people where you feel welcomed. And then, then the social rejection is less of an issue. So.
Exactly. Well, I would also say also helping Alex to focus on even small changes, physical changes as he's transitioning, because we know that he's already, on hormone therapy. And so helping him to pay closer attention to his body and even appreciate the small changes that are helping him become more masculine. And then think about other things that maybe he's interested in to help him build that identity, so that he's not feeling so disconnected from his own body. Other thoughts on relapse prevention?
I guess depending on, what the substances are, just making sure that he has access to medication assisted treatment in a kind of safe environment.
Definitely. And with the level of alcohol use, the other thing I'd be concerned about would be either undergoing medical detox for the alcohol, or for some reason he's unwilling to do that, then the secondary would be harm reduction and see if you can get Alex to gradually decrease his alcohol consumption. So
Yeah,
awesome.
maybe to think about a camprosate or naltrexone. We often in this
Yes.
group, because we are talking about opioid and alcohol use disorders, we sometimes get into that quandary about, how to manage both. But a camprosate, would also allow for buprenorphine or methadone treatment if he needed that.
Yes. And honestly, I'm so grateful for those medications. I'm working with a client right now who was discharged from inpatient rehab, I guess 3 or 4 months ago on naltrexone, and it has worked so well for him. He reports like he does not struggle with alcohol cravings at all, which shocks me. I never went through inpatient rehab. I only did outpatient. So I'm always shocked when when I ask him about cravings, and he's like, yeah, I'm really not having any alcohol cravings. I'm like, that's awesome. So the other one I know my clients have benefited from is the injection, the Vivitrol injection. So a lot of them have found that to be really helpful as well. All right, well, I'm going to stop sharing there and I'll open it up for questions.
I think one of the
There's not
questions.
enough, sorry,
Oh, please go
not
ahead.
enough time for a discussion, and trying for once in my life to avoid making anything political. Maybe you could slip us a reference or two about the transgender experience amongst children and adolescents. It's at least 2 or 20 hours worth of conversation, but I don't really know where to start to provide useful information.
So as a starting point, and so because yes, especially among adolescents, transgender exploration has definitely increased exponentially over the years. One easy local resource, if there's one in your area. Now, there's one in Cleveland, but I haven't checked Akron. There's an organization called PFLAG, which was actually formed in the 70s and 80s to support gay individuals. It's parents and friends of lesbians and gays. But I will tell you, having attended some of the meetings in Cleveland, that a lot of them have become awesome. So PFLAG is a great organization to refer parents and their adolescents to. I was shocked at how many parents and transgender adolescents attended the PFLAG meeting that I went to in Cleveland. And I think there was a real benefit to parents and the adolescents being able to hear each other and what their respective challenges and struggles were in the process as they're going through it. And it definitely helped them feel not so alone. So that's definitely a great resource to refer them to. And other than that, I'll have to poke around a little bit. I know there's a National Transgender Center for Excellence based in California. So that's another place that I would recommend that you look for materials. But I'll see if I can poke around and send some to Kara and have her distribute those to the group.
And thanks for that. And we only have about a minute and a half left. But one of the things in this is probably a can of worms. But I know some of the individuals I know and or have worked with feel real targeted with the political vitriol of the last year or so, and feel more abandoned and feel a greater stigma than they had in the past. So how do we find safe places for them? Because I've shared with an individual and just told him to let's have a moratorium on watching the news for a little while.
Absolutely. I think that's so important. Really working with them to stay off of social media and stay off of the news. And so one example that I've used with clients and I use for myself is I only allow myself to check the news once a day in the morning when I'm feeling strong. And if it's a day when I'm not feeling strong, I don't check it because I definitely feel what they're feeling. I mean, I've been an activist and a researcher in this area for 30 years. And to watch the clock get turned back to the 1990s, but worse, has been devastating. And if I'm feeling that way, I can't even imagine how the younger generations are feeling. So any strategies that you can give them to manage, especially anxiety and depression right now, and also remind them that there are still organizations in the world doing good work. So Lambda Legal, very active. ACLU, GLAAD, Gay and Lesbian Advocates and Defenders, very active. Human Rights Campaign. There's still safe spaces for them to go. I know at least in Cleveland, they still have the LGBT Community Center. I know there must be local organizations in Akron as well, where they can go and be among their peers and actually share some of this frustration with other people who are experiencing it.
And thank you for that. Right now it is 8 o'clock. I